Welcome to the Nursing Home Social Work Network webinar series. This is Mercedes Byrne-Klug at the University of Iowa, and I'm here to welcome you to today's webinar. If you are currently working in nursing home in any capacity, we want to extend a thank you to you for the care that you give America's residents and families. And if you're an advocate or a policymaker or a concerned citizen, welcome as well. I wanted to let people know that we have at least 2 webinars per month. We have a best practice series on Tuesdays that is specific to psychosocial care and the role of social services and social work in the nursing home. And then on Thursday, and in fact this Thursday we have a webinar. It's the topics are more emerging issues, kind of background information, and people in any discipline are welcome to attend either of the webinar series. I'd also like to thank the Retirement Research Foundation for the financial support which enables us to offer these webinars at no cost. If you have a question and you're part of the audience today, please go ahead and use the chat box and type in your question. We will have an official question and answer time at the end of the presentation. And then also please know that today's webinar is being recorded, and the recording of the webinar will be posted on the Nursing Home Social Work Network website probably within about a day. The speakers start, they'll talk for probably about an hour, including a case study, and then we'll have another 15 minutes of questions and answers. So please, if you have any questions, jot them down so you don't forget them, and then go ahead and type them in for our question and answer period. And now to introduce the speakers, I'm going to hand the mic over to Bob Conley, social worker. He has 20 years experience working at the Center for Medicare and Medicaid Services, otherwise known as CMS. In fact, was the project officer for the MDS 3.0. He's a member of the planning committee and a co-leader of this webinar project. So, Bob.
All right. Well, I have the privilege to find speakers in today. The topic is family members and coordination of care plan meetings. And I'm really excited because Elise Beaulieu has just been awarded her PhD. She's already an MSW and has the bachelor's, but she had her defense, I believe, on Monday at Simmons College, so we just congratulate her. She's been a contributor, and I've known her for at least 10 years, and she's brought practice experience and really ground-level knowledge to adults and those with disabilities and nursing homes, rest homes, and visiting nurses. She's also been a teacher at Massachusetts colleges and really helped develop the Boston University webinar series that's an initial model. She's currently the chair of the Nursing Home Shared Interest Group for the state of Massachusetts, and it's her annual meeting. Not aware, you may want to be aware that she's written a wonderful book called A Guide for Nursing Home Social Workers, and it's in its 2nd publication, which means it's being read and is vital to people around the country. Joined today by Deb Beringer, who's the Director of Social Work at a retirement center nursing home in Iowa. She's a BA in Recreation Education with a therapeutic emphasis from the University of Iowa. And she's her BSW from the University of Northern Iowa. Before coming to nursing home, she had worked for 9 years in home daycare. And being one of our first BSW speakers, we want to encourage any of you that want to participate in our webinars that we want BSWs, MSWs, BAs, other degrees, because we realize nursing home is a mix of many of you with different So I'll turn it over to Elise, and once again, congratulate her.
Much, Bob and Nurse, for having us here today. It's a pleasure to be participating in this, and it's a very wonderful way to reach the nursing home social work community. And coordinating family care meetings. For our presentation today, we are hoping that at the end you will have a better understanding and background of nursing home family meetings. We also hope that you will be able to identify family systems theory approach that we'll be talking about briefly. We're going to cite some specific federal regulations for care plan meetings. We're going to understand the best practice and realities for care plan meetings. I've provided a simple plan of documentation so that we can have an idea of how we should record what we do in the meetings. And finally, is going to provide us with a wonderful case vignette that I think you will find interesting and stimulating. Now, next. Okay. Things in the nursing facility. The ship of meetings really helps to set the stage. For example, if the minimum data set nurse, runs a meeting, information may tend to be medical and focus on existing care plans. Many of us have experienced that. If the social worker runs the meeting, there will be an opportunity for the resident and family to participate and contribute to the overall topic of the meeting. Running meetings is an important role. One, be skillful and aware of boundaries, times, as well as providing an opportunity for everyone to be heard in a way that is constructive. And by that, because sometimes people want to talk, but they're not necessarily constructive. So you want to help direct that if you can, to have people, everybody hear their voice. Gently directing a runaway conversation, a resident or a family member can take both compassion as well as tact. But for the meeting to be meaningful and productive. The meeting often drives the way in which a meeting is run, as well as the outcome. We can rule two types of family meetings in the routine care plan. We can have specialized meetings. Plan meetings are often brief, purposeful, address key care plans, and determine if these are in keeping with the resident and family goals. Presenting issues, a time for a specialized meeting can be or should be arranged. This meeting can include discharge planning, conflicts, or urgent status that may include a revision in a previous plan of care. Attend shape the meeting too. In some cases, the residents can inhibit families from speaking only. In other cases, the can inhibit the resident voice. Status key staff members can be absent or dominate the meeting. And about some of the other variations a little later. The expectations for meetings are also important. You want to be sure that and again, introducing the meeting and the reason that you're there helps to set the stage. And I believe in setting the stage is an important role for the social worker as well as the members. I'm going to family systems theory approach to understanding families. When a person is admitted to a nursing home, he or she brings other members and past function as well. This includes spouses, some ex-spouses, stepchildren, extended family, as well as neighbors and friends. And again, all of this is under a microscope. If you want to think about the fact that we all have interactions with our family members, our friends, and we have a spotlight on it, not necessarily anybody's observing it. But you're admitted to a nursing home, you're under observation of a host of folks. So behaviors and all the interaction is basically magnified. These can present support challenges to the care being given in the nursing facility. Often accustomed to the changes that occur to individuals who are admitted: stroke, exacerbation of dementia, fractured hip, pneumonia, etc. These represent a crisis for the family. Crisis in its nature is a disruptive way of functioning. So you have a set pattern that you're used to. Say spouses, and one spouse always makes coffee for the other spouse. When to the nursing home, that microcosm of interaction is disrupted. For each person, it's a readjustment of role, readjustment of interaction. How do I visit that person in the nursing home? And talk about it. It's a process to determine also how permanent the new state will be, particularly when we're talking about a dementia situation. Take into consideration cultural differences in families as well. Much of what has been written for family theory is based on Western ideals. And to recognize healthy cultural differences in residents' family as maladaptive patterns that can be presented in or prejudicial views. Provide care for the resident, and this can be important in how they relate and how they become enmeshed in the family system, or they become resistant to being enmeshed in the family system. That presents difficulties. Sometimes staff can feed into this. Support of the social worker to help point out when these qualities are emerging and may become troublesome or barriers to good care. To be of help to staff while you are sensitive to the impact of change in these relationships. Let's count very helpful responses and strategies, and it can spiral into accusatory and angry behavior. That you can think about families who appear to be wonderfully supportive to a family member who's admitted. And you want to look at those qualities of action and want to see if that's the same as or different than the other responses that you had. I had a family member who came into a facility, and her husband, who had been her primary caregiver, was frustrated with her behavior, that he came in and dumped all the care supplies in her room. He wasn't coming back. Of course, this generated a crisis. The nurse appropriately sought out social service to help resolve the situation. When I met with the resident, she was ashamed of the interaction. She describes their relationship as being very, very good up until this point. And she wasn't sure what the outcome was going to be in terms of returning home. Well, their relationship had been rocky on and off, and he did return. We asked him to address some of the situations that were going on, and he agreed that he had these private discussions, but they were spotlighted in the facility. It was that much more difficult. So, long story short, in this particular case, it worked out fine. She went home, and he continued to be her primary caregiver. The caveat to the whole thing, as she had been giving so much of her dignity and self-care over time with her illness and her disability. What we did is we put into effect that he was going to ask her permission to engage in caregiving. And then when he would say, would you like me to do your dressing? Would me to come back and see you again? And this way we empowered her and gave him a role that he was very willing to do, but was continually pushed off by her as she struggled with her empowerment. So, I knew the Bowen family. Kind of take a look at how interaction and relationships of families are pulled in. Resident families come to, as I've mentioned, to the facility with previous functioning systems. Theory helps to understand and sort out some of the ways in which people act with one another. For discussion here, I'm going to focus on Bowen's theory, as he's the most well-known. Some websites at the end of this PowerPoint for further information if you would like. Bowen's theory describes family emotion process over generations and the way that it influences how people can function as a part of a family unit. Some individuals are freer of sensitivity to others and freer to go in and out of his own, her own self-determined direction. Others not fit so well with the needs and expectations of the family. In situations, they may be focused on negative or unrealistic patterns. Obviously, no family is perfect, nor does the function of one person always meet the needs of another. I would have learned that in my example of my woman who was being cared for by her husband. Bowen suggests that families are organized to produce diversity in functioning and adapt to various circumstances. These see how emotional systems are organized in a neutral way, give individuals more freedom of being sensitive and less reactive toward those who be caught in the automatic and reactive dance of life. Listed 8 concepts of a family. And the levels of differentiation of self. Family and social group affect how people think and feel and act. It will vary in their susceptibility to groupthink. Groups vary in the amount of pressure they exert on conformity. The less developed a person's self is, the more impact others have on his or her functioning. And he tries to control the functioning of others. And one of the things that when we run into difficulty with families, daughters, sons who are overly conscientious or overly concerned about a resident's we can want to think about what levels of differentiation of self are. Bowen developed a scale to measure differentiation of self. You can try out in the nursing home if you like. Family. This describes 4 relationship patterns to manage anxiety. There's marital conflict. There's the addiction in one spouse, of one or more children, and emotional distance. Now, I have here again about managing anxiety. Think about what it does to a family member. This is not being in a nursing facility, being in a care facility is not, I want to put quotes, normal. So how do people cope with this? Again, these are the ways that Bowen has mentioned: the marital conflict, the dysfunction of one spouse, abandonment of the children, and emotional distance. These are automatically activated as anxiety and stress increases. Anxiety is absorbed. The history of sensitivity in the relationship plays itself out and governs where the problems are likely to develop in the family. Tend to function at higher levels if they use many mechanisms and not just one. It's for people to become aware of the automatic nature of how we relate to one another and alter our behavior. So when I was talking about marital conflict in our employer earlier, that's how they work their difficulties out. He does her care stuff in one spot and stormed out. Again, that was anxiety and stress. So by doing some simple intervention with the husband and the wife, we were able to change a little bit about how they functioned in that way. Okay, projection process. This describes the way parents transmit their emotional problems to a child. Now, talking about adults here, we're talking about people in their 80s, with children. So parents have a great deal of difficulty separating from a child. Imagine how the child is rather than having a realistic appraisal of a child. The problems that most negatively affect a child's life are a heightened need for attention and approval, with expectations, the need to blame oneself or others, responsible for the other's happiness, and acting impulsively to relieve anxiety, the anxiety of the moment, rather than tolerating anxiety and acting thoughtfully. Some of these situations, you can take a look at our residents who are dealing with their children or children dealing with their parents in the facility. You can see this process continuing on. Multiracial transmission process. This describes how small differences in the level of differentiation between parents and their offspring over many generations. And there isn't much differentiation among the members of a multi-generational family. But when one person relates to the other, creates differences, which are transmitted, again, across generations. People are sensitive and react to the absence or the presence of relationship, to information about this moment, the future, or the basic genetic inheritance, and shape the person's self. Sibling. We often look at different siblings, the sibling that's left behind, for example, where the other siblings are miles or even trees away. Grow up in the same sibling position have important common characteristics. For example, oldest children tend to gravitate to leadership positions, and youngest children often prefer to be followers unless parents disappoint them. Research shows that spouses' sibling positions, when mismatched, are often affect the chance of divorcing. And in my practice with older adults in particular is that the child's position, sometimes have the oldest child who's to take responsibility, who has abdicated that role. When have a situation taking place, you often find other children resenting it and resenting having to take that role. Well, my older brother is useless, or my older sister is useless. I have to take over. Or little child say, my oldest brother doesn't manage well, and my younger sister doesn't manage well, so I have to do this. Triangle is a three-way person relationship system. It's considered a triangle is considered a molecule of a larger emotional system, and it's the smallest stable relationship system. People can manage more tension than a two-person relationship as the tension shifts among the three. Try to exert social pressure by putting one on the outside and bringing an outsider in when tension escalates between two. Increasing the number of triangles can also stabilize tension. Marriage therapy uses triangles to provide a third neutral party capable of relating well to both sides of the conflict. And that's where a role as social workers can fit in, that we're doing marital therapy, but we're also providing a way to spread that tension among three people. Sometimes you can do it with a child and a parent in the nursing home system. Still cut off. People sometimes manage their unresolved emotional issues with parents, siblings, and other family members by reducing or totally cutting off emotional contact with them. This resolves nothing and risks making new relationships too important. But there are some times when the emotional cutoff is necessary. Oftentimes, people with a history of substance abuse or severe mental illness have to manage contact with a family member in a way that is more and not close. So take a look at the emotional cutoff if it's not total and permanent. The social emotional process. This concept is how emotional system governs behavior on a social level, and similar to that within family, which promotes progressive and aggressive periods in society. So, okay, let's go move on off family system to facility staff. Meetings and talk about family planning. It's important that we, the facility staff is basically part of the family. The staff is often treated to the same types of communication that a family has with one another, whether that be good, bad, or indifferent than other family members. Strives for consistency with all family members and, of course, hopefully with one another. But it's really important that everybody, I call it being on the same page. Staff is unsure of information about a resident or information about a discharge plan or something, they should report this and then gather the information and get back to family. They have one voice, not several different voices. A member who says, gee, maybe over this past weekend we had the flu here. I'm not too sure. Although information may be conveyed in good faith, at times can families that aren't too well balanced into a tailspin. Difficulties. These difficulties be shared with the family and presented with a resolution. For example, Mr. Jones was very agitated last night. He almost tumbled out of bed. So I get this to a family, and this can be very distressing. You do that. Instead, Mr. Jones had a restless night. We helped him up and provided a snack, and then he went back to bed and slept for the rest of the night. The two may relate the exact same circumstances, but the second one provides the family with, oh, you managed his restlessness, you managed his care, and everything was okay. And in a timely manner with families is very essential. One can ask a family what is the best way to communicate and then comply with this as you can. If, for example, ask for multiple people to be notified, explanation is needed that can happen or why that would work. I had one family member say, well, you can call me between the hours of 7 and 8 at night, but after 9 at night, I don't want to be bothered. I want you to call someone else. And if they're not available, here's their number. Just this is going to happen. We try to explain there's shifts of people working, and everybody may perceive this in a different way. So it's important that what we can and can't do with families very clearly, hopefully provide them with good information. Many family meetings can address problems with communication as well. That's another biggie for communication. Families. Okay, federal regulations for care plan meetings. Looking at R2 there, which is the regulation 483.20, the resident assessment. It means that you have a comprehensive assessment on all people. This until 1987 with the Nursing Home Reform Act, OBRA, the care meeting was facility-based. Some organizations, such as Belly Enterprises, a while back, put forth the idea that the care plan attendance with the resident and family was important and to utilize this. In many facilities, this was not the common practice. Reform Act changed this. Routine areas there are the focus of a plan of care, and it is indeed resident focused with input from the resident and family representatives. The goals are the quality of life and the highest practical functioning of the resident. All residents should be and are supposed to be encouraged to participate in the care plan unless he is adjudged to be incompetent. Family representatives also encouraged to participate in the plan of care. A family member may be excluded, however, at the request of a resident. Some may have sheets where a resident at the time of admission decides who or she wants to participate in the care planning process. So yes, certainly have assessments that are due the 14th day, the 30th, 60th, and then 90 days. Significant changes where we have meetings to address these things. Okay. Here we have meetings. And best practice and realities are those that are scheduled and have full attendance of all those concerned. Careful explanations for the purpose of the meeting, the type of these meetings, helps to set the stage for maximum participation by all those concerned. The resident is admitted. The admission process is to let the family know about these meetings and its purpose, and who will be attending. It would be possible for a date to be set for the next scheduled meeting at that point. Routine notices are oftentimes made out to responsible parties or are given to the resident in the facility. Residents should be encouraged to attend if they have a responsible party, and sometimes the social worker does this. Participation in meetings can be difficult. Every staff member who is involved with a resident should be attending and be just limited to nursing, rehab, dietary, social service, which include the CNAs and other discipline that may be involved, just hospice, or managers from the Department of Mental Health, developmental disabilities, managers in the community, and sometimes even visiting nurses who may be providing help for somebody when they return home. And individuals help set the stage for the plan of care, and it's also representational of the resident's optimal dignity and self-determination and quality of life. The ideal care plan is not merely a representation of a diagnosis and intervention. It should be a dynamic interplay of resident preference and facility service. Responsibilities. Sometimes in some facilities, care plan meetings can be marginally adhered to because of staffing issues, preferences, or even the culture of the facility. Sometimes you will only have nursing and social service at a care plan meeting. I had some, once in one facility, I actually held a care plan meeting by myself as a worker. That's not the best plan at all. And these meetings obviously have some very big difficulties when you don't have all the people present. Some staff don't attend. able to attend, but we can encourage them and make it happen as best as possible. The hot potato of who sends out the care plan meetings takes place in many facilities. The social worker often left to address envelopes and send out these notices. And we can talk about this later in our discussion. That's so that we determine how we are going to get this information out to families and what's the best way to do it. Families are often busy and can't attend when meetings are scheduled. We've utilized Skype in some facilities where I've been. Conference calls are often another way that everybody can be included. Staff are resistant to attending meetings because of heavy work schedules. For example, important contributor may be a certified nursing assistant, but with a heavy assignment, this person may not be able to attend or even be willing or uncomfortable to speak at a plan meeting. But we encourage this to happen. Meeting completed remotely may be due to the reluctance of participants to attend. And when I say completed remotely, sometimes the plan information is just sent from one location to the next, and everybody just signs off on it. This is not effective, and we should strive to reduce that. Document is an important part of the meeting. In addition to being a record of the topic, the attendees, and the intervention, it provides a roadmap of what needs to be done, who will, when it's done, and forms the foundation for monitoring progress to that goal. Data is often placed in the patient record to provide documentation for meetings following the meeting. This will be complicated, but it's a simple list of what was discussed, attendees, and tasks that everyone has agreed to. I use this with a splice meeting either because of a problem or use it at a discharge planning meeting where we'll talk about somebody reaching to the community and multiple services involved. By written summary at the end of the meeting and in the meeting leaves at the same time with the same picture, and there are your questions. I will here on the next page. I don't know if this is quite small, but you can have a
Also, I have it written up here for folks.
Oh, okay.
I reformatted it, and also it's on the website. If anybody wants to download it, it's there. But are you through this, or you just wanted them to see it?
I'm gonna just give it a little highlight here and talk about why I chose to do what I did.
Okay.
Okay. First of all, what I did was I labeled it as a family meeting. In this particular case, it's the Dalton family meeting. And I put the date and wrote down who was involved, who was present. Now, I've had some people say they don't want their names in the records and so forth, but it's kind of silly if you're looking at who's attending a meeting, the family has a right to know who was there and what their names are. Again, this is something that you could hand out to the family. It doesn't have to be typed up. I did type it up so that you could read it, but you could handwrite this easily. The purpose and the discussion, I wrote down discussion because I thought that would be an important, these were the important steps in this particular meeting. And here I have the resident has concerns about her diet in the facility. She's expressed a wish to return to her apartment with services and help of her family. So we actually have a couple of things here in this particular meeting that we addressed. Wanted to address the fact that she was happy with the food. We also wanted to talk about her returning to the community. So basically outlined how information was provided and the way it was provided. So we have currently provide Mrs. Dalton with an assistance with all ADLs, bathing, dressing, and supervise her transfers from bed to chair. PT working with Mrs. Dalton to improve her strength and endurance. OT is working with Mrs. Dalton to improve her care, and anticipates they'll be able to reach their goals by, and I said 11/30/13. So right now, I mean, in that sentence, we have an idea of what's going on with Mrs. Dalton, and everybody agrees that it's happening with Mrs. Dalton. So when they leave the meeting, they will have this in their hand. Discussed. The resident's currently on a low-salt diabetic diet. She didn't like that. She didn't like the choices. She thought the food was cold and the ice cream was melted. So what we were working here is complaints. With the dietitian who was present, we had a great deal of opportunity to make some changes for her. The specific discharge plan was discussed. The resident's family said that they were limited in their ability to help once she was discharged. Now, this is a really important picture because once this is on the meeting, a better way to send with what kinds of things that needs both and how to fix it because she didn't want to come home. So, we discussed this whole process and we wrote it down. We tried out options, home care services, and came up with a plan. And done here is I've actually created a list where the nursing encouraged the residents' greater self determination and her independence and self-care, safety and cooperation with all of this. Team also was going to discuss discharge with the attending physician. So we have all of these tasks, and if you look here, we also had dates. Who was going to do what and by that time. And the social worker was to contact the visiting nurse services for anticipated discharge and to ensure everything that was going to be complete for her discharge. So in this particular case, the person and both the resident and the family member left that meeting with that information in hand, and a copy of it went into the chart, the worker's signature. Okay, special meetings. And that was an example of a special meeting, but it could have also been part of the care plan meeting that was scheduled for an admission individual, the initial care plan meeting. It's going to be arranged by facility staff or at request of a resident or family representative. On the of a resident status can indicate the need for a further care plan discussion consideration, such as decline in health that might indicate a hospice referral, or an improved status of a resident that might suggest an alternative living setting. Care meetings are often special meetings because of the urgent nature of planning, as well as the movable dates, times, and resources that must be coordinated. Homes can also initiate meetings, and these can include residents' non-compliance with, say, smoking restrictions or types of behavior, such as arguments with roommates, staff, etc. The print of staff and a social worker for these meetings can help make them more efficient and effective. Where staff may be stressed, it's important for the social worker to help prepare an outline of what will be discussed, and the staff leadership and who is contributing to what topic. When I have a meeting, a special family meeting, I will talk with all the individuals just briefly. It doesn't have to be an extended conversation, but I speak with them and talk with them about the what's going on with the person. Gee, we have Mrs. Jones and she wants to go home. This is a little bit reluctant. I'll speak with the nursing staff about what needs to be done. And in that particular case, you know, we have a lineup of what we're going to say once we get into that meeting. Financial changes can also initiate special meetings, particularly when there are questions about financial liability, blurred responsibility, and the necessity of making a Medicaid application or seeking another setting even. Okay, what are some strategies? I want to leave you with some strategies because I think that that's really important when we're talking about these meetings. There are two types of meetings, as we said before, groups, the staff and the resident and family. And again, the planned meeting with the family, you identify within your own staff who will run the meeting, the topics to be addressed. One is you want to, again, I keep going back to some of the meetings that I've attended in nursing facilities where the MDS nurse walks in and says, I am MDS nurse, and proceeds to read the care plan. We need to make sure that we don't do that. Translate for the family as much as possible and the other attendees. It will encourage family members and residents to write out specific concerns before the meeting. I suggest this because oftentimes families will say, gee, I forgot to mention such and such, and that's really pressing. Family members who will be attending the family meeting, members, I shouldn't say family members, the team members. The time frame for the meeting, be clear that there will be a time limit. If the meeting is only to be 45 minutes long, you must say so. It's for families who present multiple problems, understand that there is a time frame. Increase efficiency. If there are problems with few immediate resolutions, pick one or two problems to address and save others for another meeting. Don't feel pressure to resolve all difficulties or issues in one meeting. It's not going to be able to do that, and it gets blurred at that point. All you families, members, as I mentioned before, the staff members with their roles, and outline the topic. We are here to address the discharge plans or medications adjustments or behavioral plans, and also ahead of time when you have these meetings, who will present first? Staff members, if it's a family member that's got a pressing problem, sometimes it's important for them to get that particular issue on the table. So to be turning the meeting over to our seminar over to Jeff and talk example. Thanks.
I will be presenting a case study of a conference that I was involved in this past year. I would first like to go over the key elements of the case. I'll call her Mrs. W. was a 92-year-old Caucasian female that had been declining cognitively and physically in the past year. Her son-in-law, who was her health care power of attorney, and daughter made the decision to forego treatment of a wound on her coccyx after much consideration of what they felt best matched her wishes and what they felt was in her best interest. Her had fluctuating as evidenced by periods of misinterpreting her environment and what she was being said and done for her, and she had increased memory loss. Others, I'd let you, her family was aware of these changes, but because she also could be more cognizant at times and make appropriate decisions, they were careful to try to include her in her plan of care. She demonstrated great distress over going to the wound clinic for treatment of her severe open area. It shared why she was more clear she did not want to go anymore to both staff and family. Family continued to have her go to the wound clinic at the recommendation of nursing until it was apparent to them that a life-limiting condition, and trips were so distressing to her that her quality of life was deteriorating rapidly. During her plan, the son-in-law shared that the decision of the resident and family to stop the trips, he shared their decision to stop the trips and requested that the facility provide comfort care versus a referral to hospice. And verify they understood the potential ramifications of their decision. Nursing educated them on the potential pain issues and care issues. Voiced understanding and said that if at some point things needed to be reevaluated based on symptoms, he was open to possible new interventions, but to please respect their current decision. I felt how hard this decision was to make and promoted their right to make this decision. Nurse expressed concern their decision would cause the resident preventable pain and distress and continued to recommend the wound center and hospice support. The problem perspective was that after feeling deep loss over the decline of a loved one and going through the emotional process of making the decision they did, feelings resulted when nursing advocated for continued treatment in hospice. They did not feel heard or respected. The problem from its perspective was that she viewed the trips to the wound clinic as unnecessary, painful, scary, and against her right to refuse care. She did not want strangers involved. Family and Mrs. Beaulieu trusted facility staff to provide necessary care. Family knew that the addition of new caregivers would confuse their mother and cause distress. From nursing staff perspective, over best wound care for best outcomes, proper pain management, compliance regulation, and informed decision-making related to Mrs. W's cognitive loss, and was substitute decision-maker fully informed. From my perspective, as a social worker, I was concerned about respect for resident and family autonomy, the guy's relationship with family, and the need for staff education. Outcomes I considered were respect for family and resident wishes for comfort care and wound care to be managed by facility staff who were familiar to Mrs. W. Nursing to be more aware and more sensitive to resident and family autonomy. Was used to obtain the preferred outcome, improved quality communication between staff and family, included at the care meeting I communicated and supported the right to refuse care when family was aware and understood the ramifications of their decision. I continued conversation afterwards with family to rebuild the trust, and I involved administration and problem solving. I provided staff education regarding self-directed care, legal authority and responsibility of healthcare surrogates, and effective listening techniques to enhance communication and relationships with family. So were they effective? Talking with the family individually appeared to be effective as evidenced by positive comments about trusting staff to care for their parent and understanding that the facility needed to ensure they understood the whole picture. Station and administration's input was effective, as evidenced by nursing accepting comfort care and wound care responsibilities. However, family was expected to sign a managed risk agreement. Worst intended consequences. For example, the administrator commented that he had heard of nursing homes being criticized openly when a deceased person presents at a funeral home with open areas and appear to have been neglected. His concern, of course, was the reputation of the facility. I talked to a funeral home director, and he said they have privacy standards. If abuse is suspected, he does have to report this to the coroner or the medical examiner. Another consequence was our facility reputation being tarnished with involved family, sharing with other family and friends the uncomfortable feeling they had at care plans. Fortunately, appears to have been resolved, but feelings may still be lingering. First, plan modifications made as a result. And a care plan intervention was added to all care plans, and directives are viewed at meetings, especially when a resident's condition is changing. It was used by myself to heighten everyone's awareness of resident and surrogate's wishes and to clarify any misconceptions staff, residents, or families may have regarding disease process, treatment choices, and roles. The state guidelines guiding this case study included the 1987 Nursing Home Reform Law, each nursing home to care for its residents in a manner that promotes and enhances the quality of life of each resident, ensuring dignity, choice, and self-determination. The Psychosocial Severity Guide makes it clear that negative psychosocial outcomes may result from a facility's noncompliance with any regulatory requirement and any regulatory grouping. In this case, there was noncompliance with respecting autonomy, which resulted in negative psychosocial outcomes of distress and guilt. In compliance with EBTAG 155, which involves the advanced directives, if the facility has established and implemented policies and procedures regarding the right to formulate advanced directives and to accept or decline treatment and other related interventions. The basis for the use of an advanced directive in healthcare today is based on a citizen's right to self-determination and the Federal Patient Self-Determination Act, condemned Public Law 101-508. Lessons learned here. Some new caregiving skills, practices have been developed, and staff have been empowered to know they can provide very complicated end-of-life care. Communication and listening skills. Awareness has been raised and systems fine-tuned, reading the role of the power of healthcare, power of attorney, the autonomy, and the importance of advanced care planning. I believe that, Mercedes, you are going to continue on now.
Okay. Thank you. You also, Elise, I'm going to unmute you now.
Okay.
So folks know. Now it's there sounds like there's something loud in your background, Elise, but I guess that's taken care of now. If anybody in the audience would like to type in a question or a comment or a reaction, that would be great. While you're thinking of your own question, the presenters put these two questions out there for consideration. How was this case similar or different from situations in your own facility? And so the family in this example was united, and they were also consistent about what they wanted. But what if the family was fragmented and inconsistent about what they wanted? How might you use the team and care planning to help the resident? So those are a couple issues. Coming in that really people are appreciating the information, so that's great. But if any comments, please type them in the chat box, and then I'll read them to our presenters. As you were presenting the case, I was wondering, why the family did not want hospice to come in, but you did address that. You mentioned that they were concerned about the resident having to get to know new people. Was that the major part?
They'd been with us a long time, and they knew their mother, and each time someone new that was introduced, it threw her off a bit. And so they really wanted the consistency of our staff to provide that care. And we're very, very close to some of the nurses. So the issue came into the more the nursing management part of it, where they with the MDS nurse, a little bit of butting heads of feeling like the nurse management wasn't listening to their wishes.
Okay. I'm wondering if the nurses were looking to hospice for some support around the wound care, or did they feel that they had the skills to handle that, and they just were thinking they make sure that the family knew they had the option for hospice?
Yeah, and that was made very clear. But because we have provided end-of-life care for a lot of different people, it was without hospice. We have just some people that prefer that for a variety of reasons. But this issue was particularly severe because of the wound care situation and the potential pain involved. But we demonstrated that we could do it. And sometimes we want hospice involved because the doctors will tend to be a little bit easier on writing certain kinds of orders for us. But once we shared with the doctor what the plan was, that became easier too, that these were the family's wishes. The son-in-law was very self-actualized. He knew what he needed, and he was their advocate. And so he never backed down what he wanted, and he was very respectful. But I know there was a period where he did not feel we were respecting him. He remained so dignified, but it was hard to see as they kept coming to him be thinking this way, Yeah.
Well, it's so important to have you there with your ability to hear both the nursing staff and also the family.
It was a little bit difficult at times, but we had this hands-on administrator who was very, very helpful in helping me with this issue.
I think this was a really good case, and when Deb and I first talked about this case, I was really so impressed and taken with the way Deb and the facility handled it, because here we had a lady who had a wound, who was treatment for the wound, and now this treatment was going to stop. I think the stoppage of a treatment, an intervention, is a huge piece in all of this, because it is about how are we going to treat this person with this preferred way of an intervention. And it goes to the heart of some cases, too, where somebody may choose to stop dialysis treatment. How do people feel about that? And what's going to happen to the individual, and how do we allow it? How do we promote the self-determination and not just allow it? And I think that's another piece to this, and I think did a wonderful job.
I have to also ask you, did you contact a funeral director just because of what this family had said to find out about dealing with the wounds, or did you happen to know that from some other way?
No, it was ironic. I went to a conference, the Long-Term Social Workers of Iowa conference, and there happened to be a funeral home director presenting, and so I went up afterwards and talked to him about this. So it was just so timely. Yep.
I thought of having a funeral director present at a conference. That's a great idea.
Yeah.
That was helpful.
Did you have a person who typed in and said, if the family was inconsistent and fragmented, I try to reach out to family members a little more, maybe some one-on-one with the family members involved to come to some kind of consensus?
Mm-hmm.
One of the attendees offers that.
Perfect start and intervention point. When the messages, especially when the stakes are high, and the stakes were high here in the sense that a treatment that was wanting to be stopped. If you had one family member who wanted the treatment to continue and another family member who didn't, and the resident back and forth on it, what would happen?
Need for support, but also need for just some concrete information about what was likely to unfold with the treatment, without the treatment, what it might look like.
Yeah, and again, there's no set answer for these situations. They're all, I think, individually determined over a period of time. And I think sometimes also it's important for the social worker to be willing to help the staff realize that there's not really a shot chance at an answer, that there's a process that may have to take place. And there may be a better outcome if we don't rush the process. 2, 3, 4 meetings before you come up with some sort of decision.
Definitely reevaluating all the time. That's the nature of our business. So that's why the care plan is active and working. You change it, and families to know that we'll always look at options for them. We'll always keep looking at things, and like the gentleman, this power of attorney said, if new information is presented to him, he would consider looking at that. And I thought that was a wonderful way to us to see that he wasn't just shutting down and saying, I want it this way. That the information he had now, this is how he wanted to proceed, but if new information arose, he would look at that. Yeah.
That was a thoughtful way to proceed for sure.
Yeah.
And I think that we need to encourage people to consider that as an option, and I think we can offer that and help people understand that might be an excellent way to proceed for some other people.
All right. We had somebody else just write in and say, I think that if each family had their own individual time to state their opinion, it would be easier to have every family member's voice heard instead of having that. And, that's back to something both Deb and Elise said. You starting us out by reminding how it might feel to family members to be under a microscope, that kinds of conversations and interactions that have happened in private all these decades, now all of a sudden you're in a hallway in an institution and in a building, and these private things are becoming public. And then also Deb talking about how hurtful it can be to the family if the staff insinuate that they're make decisions that aren't in the resident's best interest. You know, that kind of suspicious toward the family. And so it really brings home the important role of the staff being heard and the family being heard and the resident being heard, and keeping those communication channels open so that good decisions can be discussed and processed and enacted. But it is a process, and trust is so important in this whole process.
And a process needs to include the way you say things, because I think that how some people can come across, you can say the same thing and someone will perceive it in a whole different way. And so I think we social workers learn how to say things, to present information and education that doesn't sound judgmental, that doesn't sound like controlling, that we're just trying to help them get through this maze of all this information and present it in a kind, respectful way.
Well said. There are no other questions or comments, so I think that we'll call it a day. I want to thank Deb Beringer and Elise from the bottom of my heart for two very interesting cases and important information, and it was good to hear about the family systems theory and see how that applies to the nursing home setting. So thank you both very much for your time.
I did bring up the websites for the Bowen family systems. You can go there. There's a nice little YouTube link that you can click on that tells you a little bit more about the Bowen family systems. And then there's the Bowen Center, where the theories are written out and provided for you so that you can take a look at those. Again, the whole idea that multi-generational transmission of behaviors and roles it's so true. You just read through this and you can probably identify disorders of the residents and families that you work with when you look at these. Although you tend to look at things that are dysfunctional, they also point out the processes that are functional and useful. And again, people are in crisis, and one crisis has been in some way. People go back to functioning in essentially more functional ways again, instead of being dysfunctional or problematic.
It's important just to remember that how people are behaving is not necessarily a reflection of who they are as a person, but is also a reflection of the situation and the stress they may be under. And so just kind of giving voice to that and supporting people.
Absolutely.
All right. If